And hi, everybody. Those of you who are just joining, thanks so much for selecting this topic. And really looking forward to sharing some of the work that our coalition's been involved with and getting into a conversation with some of you around where the needs are with regard to community-based care. So yeah, we're good to go. I think I'm getting a thumbs up from Divya. So again, welcome everybody. Thank you so much for joining this morning. I'm gonna just share my slides. So give me 1 second. Hopefully you can all see my slide now. Let me just put this in show mode. Okay, so you are in session 1.3, and we're going to spend just the next couple of minutes talking about some of the innovative work that our coalition has been leading to help expand access to more supportive services that are community-based. I'll spend just a couple of minutes in the beginning talking a little bit about our coalition, just for those of you who aren't familiar, have a little bit of a sense of who we are and what we're doing. And then I'll spend really the bulk of the few moments of presentation around some of the innovative research and policy work we've been doing to help advance our mission of expanding access to home and community-based services. And then, of course, we'll open it up for questions, and hopefully there'll be some good discussion. So I just wanted to share a little bit about the history of our organization. The Goals of Care Coalition, or Goals of Care as an organization, was actually originally founded in 2009. At the time, it was founded by Dr. David Burrill, who is a geriatric physician and also a board certified palliative medicine physician, but he formed the coalition in response to data he saw coming out of the Dartmouth Atlas, which many of you may find familiar, that really showed that New Jersey is the worst state to die in. What I mean by that is that in the state of New Jersey, patients with complex, advanced, and chronic illnesses spend more days in the ICU, more time in the hospital, are seen by more subspecialists, and actually at a cost of about 20% more than any other state in the entire country. And Dr. Brill wasn't the only person to notice this at the time. Many leaders in the state thought that there was something that could be done to address our very poor performance on end-of-life care measures. And so under the Christie administration, an advisory council was formed of thought leaders across the state to work on these issues and try to improve end-of-life care in New Jersey. And under the Murphy administration, a report was issued from this advisory council with a number of different recommendations to try to improve care for people with serious illness. The number one of which was to form a coalition like ours to bring all of us who are already many working on issues and opportunities to improve care under one umbrella, with the idea of trying to better communicate and coordinate and really establish some collective impact for all of the work that we had all been doing to try to improve care in the state for people with serious illness and for older adults. So today, our organization is a nonprofit that represents many of the different organizations that are made up of the interdisciplinary team of providers who care for our older adults and people with serious illness. You may recognize many of the logos on this chart, but it represents not only physicians and nurses and social workers, but also doulas and chaplains and others who are involved in caring for people with serious illness across the entire continuum of care, those who are cared for in a long-term care facility or in the hospital, and those that are cared for in the community. And we also have, as part of our coalition, those professional and academic institutions that are training the next generation, so we can be ensured that we have our work embedded in the curricula of these pre-professional programs. I just want to spend a second talking about our vision, because this really is overarching, driving all of the work that we do. And it's our hope and intent that every patient who is dealing with an advanced, complex, or serious illness get the care they need and the care they want. And for us, that is really executed under three main platforms. It's through research, education, and advocacy. And for the remainder of the presentation, because this is on innovation and some of the innovative work we're doing, I'm going to talk a little bit about the research work we've undertaken and how it's led directly to our policy initiatives, which is really the crux of the rest of the presentation. But I don't want to move on without saying that for our organization, it is the individual's values that we believe ought to be at the core of all medical decision making. And it is that patient and their caregivers honor that and dignity that we wish to honor in the caregiving process. I think that oftentimes the humanity in medical decision making is lost, and we really want to create a standard of care where no matter who you are or where you're receiving care, that care is aligned with your wishes. So I said I would kind of focus on the two key areas that are the priorities for our coalition, which are research and advocacy. And it is really a focal point of our research to understand gaps in care that exist for older adults and people with serious illness, particularly in a state like ours, where there's a lot of work being done to expand home and community-based services. And we believe that it is part of our mission to be addressing the disparities that we identify through that research and promoting equity by putting forward and advocating for policy change, specifically those that increase access to community-based palliative care service. Our organization has been leading some efforts to try and secure a Medicaid benefit for community-based palliative care. And while we've been successful in actually getting a piece of legislation passed, and I'm going to share that with you in just a moment, the work over the next couple of years will really be focused on designing that benefit. And I encourage all of you to get involved with us in that process. It is only through the engagement of stakeholders, patients, their caregivers, unpaid and paid, and the community that's caring for this population, that we can really ensure we're addressing barriers to access and providing the services that this population really needs. I'm not going to focus today on education, but know that in the entire cycle of activity, our research really drives our policy and advocacy work. But in the end, it is the education programs that will drive people into the programs and create awareness. I see there's some things in the chat, and we will definitely get to questions and have an opportunity to talk further. So please put your questions in the chat, and we will definitely get to them. Okay, I want to take a minute just to talk about research. Our coalition was fortunate to have received a grant from the Department of Health's New Jersey Commission for Cancer Research. And we really have two main deliverables from this research. The first is a report on where, how, and to whom palliative care services are currently being provided so that we can begin to understand where those gaps are, and to provide a directory of providers in the state who are caring for this population and who can provide palliative care service in the community. The main questions we're asking are on the right side of the slide, and I'm not going to read them all, but the idea is for us to collect information on where services are being provided, who's receiving those services and who isn't, so that we can then begin to work on access issues and work on the efforts that need to be undertaken to ensure we're increasing access for all patients in the state who need access to this type of care. And I'm sharing with you a little bit of a sneak peek into the research. This report will be released at the end of June, and we're in the process of collecting the data and analyzing it now. But it's important to note that there are very serious areas in the state where there's high unmet need. So what you see in the graphic on the right side, those areas shaded in green are where the bulk of the Medicare beneficiaries live. So these are the 65 plus population with chronic health conditions or advanced illnesses. And the circles that you see superimposed on top of that are the palliative care providers in those communities. And you can see in the northern half of the state, there's a lot of need and there is a sufficient capacity to deliver care to those providers. But look at the southern part of the state. There's tremendous need and still a significant gap in terms of provider capacity. This is something that we're going to be addressing over the next 2 years, and something that we're going to need to be working with the provider community on to ensure that those patients actually have access in their communities to the community-based palliative care service. All of that data, coupled with what we know and have learned from national experts who've looked at the provision and benefits of community-based palliative care, were used to begin a conversation with our policymakers and government agency leaders in the state around those serious gaps in care and some solutions that could be deployed in order to address those gaps. And so about a little more than a year ago, the members of our coalition testified at a hearing in the Assembly's Aging and Senior Services Committee and began the process of working with lawmakers on a piece of legislation that would mandate through our Medicaid office the provision of a community-based palliative care service, a package of services that would be reimbursed and provided to patients who would meet the criteria. That process began in February, and I'm not going to read all these dates and activity on this slide, but it's important to note that that piece of legislation passed through several different committees within our legislature. And between February of last year and the middle of December, that legislation was unanimously passed by multiple different committees and landed on Governor Murphy's desk before the end of the year. And I'm proud to say that Governor Murphy signed this legislation on December 21st of 2023 last year and gave the state 2 years from now until the beginning of 2026 to do the work to hear from stakeholders about those gaps and barriers, and to ultimately design a benefit that would address the specific needs of the population it's intended to serve. And the reason that this is so innovative is because we are one of only a very small cohort of states across the country who are working on this. while 21 states have some information in their departments of health or are working on policy related to palliative care. There are only 15 states in the country that are currently working on a Medicaid palliative care program. And we've used some of those states as the benchmark for the work that we are trying to do here in New Jersey. And the really, I think, big benefit to New Jersey in not being the first is that we have a lot of important lessons that we can learn from California and Hawaii and Colorado and Washington State, where some of this work has been undertaken and in place for a couple of years. What we've learned and what we know is really important for us to get right is that the importance of creating awareness of these programs, of educating both the patient population and the provider community about these programs is key to getting people to use them. And that is something we're going to need all of your help to be able to execute and do well in order to make sure people who are eligible for the benefit are actually using it. So we're going to count on all of you to help us in that process. Establishing the mandate for this benefit is really only the first step. And what I really wanted to share with you today is that there's a lot of work to be done over the next 2 years that will focus on the specific design of this benefit and working both at the state and federal level in shaping what these programs ought to look like. And ultimately, as I said, the success of this entire effort will depend on the number of patients who enroll in this program. And for that, we're going to need a lot of education and training. And all of you, I hope, will play a role in that work. This is really my last slide, and I just, before we open it up, wanted to highlight for you all of the work that is ongoing over the next 2 years. This is just some big buckets of activity. I mentioned the need and capacity research, and we are going to be launching our provider directory again at during the summer. But we will already begin the work to try and now identify specific gaps in the services that are being provided to this population, and then bringing various different groups of stakeholders together to talk about those barriers and those gaps and the specific needs, so that when the benefit is ultimately designed, when the services that are going to be covered are recommended, when the staffing requirements are recommended, etc., they will all meet the needs of this very diverse population of vulnerable people who would ultimately benefit for this. And I'd encourage you all to participate. In fact, put your name in the chat and I will make a record of it. As we are bringing stakeholders together, I'd invite you all to participate in those meetings. So if you're interested, please reach out to me and let me know. Put your name in the chat and I'll be happy to reach out to you when we're getting those stakeholder meetings underway. And I think I'll stop there. We'll open it up now. I know we've got a few more minutes, maybe 15 minutes or so, Divya, yeah, for questions. So please take yourselves off of mute. I'll stop my share and I'm happy to answer any questions or talk a little bit more in detail about anything that I shared. So are there any questions, anything specific around the work that we're undertaking? Kara, please.
Hello. I mean, I'm just thrilled to see that there is a coalition I didn't know existed. I've worked for 3 years at Abington Jefferson Hospital in Pennsylvania, 8 years in the ICU, specifically in trauma area. I've worked for Mainline Health for 8 years, ICU, being a supervisor in social work in that platform. And then it was difficult then. And I seen the people living on the ventilators and going from LTACs to acute rehabs back into the hospitals and just constantly, and everyone just trying to live with no quality of life when the actual person may not even want that. But as soon as you get intubated and then you went for your trach, the family feels like they would be killing them. So they don't, and I can't say that I didn't feel that some of these hospital systems just kind of don't want that mortality rate, that some of the nursing homes, you know, would be content with the Medicaid dollars to have that person live a bedbound life. And that recidivism of septic shock and bed sores is so horrific that when I came to New Jersey and worked at Jefferson, Washington Township, I was actually horrified by what I saw and ended up leaving after a year and a half that particular hospital, and coming to work as the director of senior services, getting into the community and doing the work and partnering with Samaritan around this topic. So I'm very fired up about this topic. I've seen it, I've lived it, constantly talking about our advanced directives and helping families to respect the wishes of others. We are not going to live forever. And everyone that has a chronic illness, chronic disease, should be involved with palliative care from the moment of that diagnosis and correcting the stigma. And how many times I tried to request a palliative consult and I'm heard, they're not ready for that from a doctor. And it's ready for what? Conversations about quality of life, about their care planning, about their goals, about understanding of disease progression and journey. What are they not ready for?
Yeah.
Yeah.
Kara, thank you so much for that. Jim, 1 second. I just want to say to Kara, thank you for helping to move this conversation much further upstream. That's exactly what this initiative is about. So yeah, the need is great, and moving this conversation further upstream will really help. Jim, please.
Yeah, Lori, could you address the who's going to bring the agency to this? Obviously, it'll be different people in different areas, but can you expand on that? Who's going to be the agent? Who's going to do the work? In other words.
Yeah, so part of the needs and capacity research here is showing us how much of a challenge from a workforce capacity perspective we have. A lot of what we are going to be trying to do on the education side as we get a little closer to the rollout of this benefit is to build the capacity, the capability, the skills of the primary care providers so that primary palliative care can be administered, and that is already care that exists in the community. I think those relationships are really important. So Kara mentioned Samaritan. They have been leading in this space for many, many, many years. And we'll rely on them to help educate their own peers and colleagues in the southern part of the state to build the capacity and ensure that there's a provider community ready to, to receive the patients who are in need of the services. I hope that answered a little bit of your question, Jim. And I think, the challenge for us is going to be in building awareness about these programs and trying to enroll as many patients as we can. So we'll need providers, social workers, physicians, nurse practitioners, and others to refer patients that they think could really benefit from this service into these programs. And hopefully that provider directory that the grant program we're working on will fund will be able to be a good resource for all of you to refer patients to providers that are accredited and are able to handle the patients you're referring into the program.
Thank you.
Divya, I wanted to answer your question about some of the challenges we faced from a policy perspective. And I think I think part of the difficulty in this work, and this will be familiar to many of you, is distinguishing and making a difference between what people, making people understand the differences between what is already being provided as part of a hospice benefit for dying people and what would be covered as part of this benefit for people who are living, sometimes for a very, very long time with their serious illness. That was one of the challenges. I think that communication challenge will persist. I see we're heading back into the main room. Thank you all for participating. Appreciate all of your attention today. Thanks so much.